Good morning, everybody. It's a pleasure to be invited to address you this morning on the subject of e-health. I've chosen the name e-health at the network edge to really give the sense that, the e-health revolution's already started in the hospital and the GP sectors, but it's only really now beginning to take off, I think, in the consumer sector. And I want to talk about some of the implications of that and some of the new services that may be delivered as a result of extending the reach of medicine and healthcare into the home and into the workplace environment. Before we do that, though, just a bit of context. IBM has an Institute for Business Value, which essentially looks at some of the emerging issues for particular industries in society. And we've recently published a paper called Healthcare 2015, Win-Win or Lose-Lose. This one here. Oh. Not sure why the volume button's just come up. I must have pressed something wrong here. We're just about to produce a new version of this paper. If you're interested, watch out for it in about 3 weeks' time. Go to the IBM website, ibm.com, and look for Healthcare 2015. You'll find this, I think, a very useful discussion of what's going to happen to the healthcare industry, the healthcare systems that we know today over the next 7 or 8 years. But we see some major drivers happening to healthcare at the moment. There's the concept of globalization, ideas like health tourism, people going to places where healthcare is more cost-effective or perhaps in some cases safer. Growing interest in consumerism, maybe more in countries where healthcare is less socialized than in Europe, but certainly there's a feeling that people are getting more demanding about what they expect from their healthcare system. Changing demographics, we all understand this issue, the concept of people living longer and living longer with chronic diseases, and also changes in lifestyles and, potential health risks like obesity starting to become very, very significant. Diseases that are more expensive to treat. Again, this reflects the idea that, people, when they develop disease, often will now have it for much, much longer throughout the course of their life, and therefore, by definition, that costs a lot more to pay for. And finally, new medical technologies and treatments, drugs, and so forth, which are fantastic, but, in the first instance tend to be quite expensive. So what we think this means for healthcare providers is that there'll be an increasing focus on the value that they get from the various treatments and therapies that are being used. There's going to be much more focus on the idea that citizens have to be responsible for their own healthcare and their own well-being. And I think we'll come on to that shortly in terms of what that means in terms of new services for citizens. We think there's going to be new approaches to promoting health and delivering care. We already see this. I think yesterday we heard some presentations that kind of observed that, very much what we see today is a healthcare system designed around acute episodic care. In other words, you have a crisis, you get admitted into the healthcare system, you get fixed, and you get discharged. And I think we're going to see a much more fluid movement of people between different elements of the healthcare system in the future, because the way that healthcare will be delivered will not depend on going to particular buildings, but instead will depend on having access to particular services, which may be delivered outside of traditional settings. And finally, we're clearly going to see growing resource challenges in the healthcare service. One of the driving factors for teleradiology, for example, was the fact that there were not enough radiologists to do the readings, and this generated a whole new industry of taking images in one location and transmitting them to another location or country, in some cases, to be analyzed. So I think we'll see a lot more of this too, as the population of doctors and nurses is not increasing at the rate at which demand suggests that it should, and therefore we're going to see providers really challenged on how to cope with the demand coming from society. We think if you look at personal health that these two are the two interesting areas as far as personal health is concerned, whether it's health information or personal health records or patient monitoring. So let me just move on now to the next thought about this. Here's a kind of a graphic to kind of illustrate where we think healthcare systems have to move to. We think that a good healthcare system has to be value-based and has to really try to push as much of the effort back to the left-hand side of this diagram as possible to create a value-based healthcare system. So in this area here, we have people, hopefully many of us spend a good deal of our life in this area. We're healthy, we don't have any high risk factors, we are essentially not a great burden to our healthcare systems. And this is where we want most people to spend most of their life. However, some of us have, genetic predisposition to disease. Some of us have lifestyles that perhaps are not as safe as they should be. So many of us do end up in this category of at risk for a good deal of our lives. Then we move into the high-risk area where perhaps the symptoms are not quite apparent yet, but nevertheless we're developing lifestyles which take us into this area where we may be running the risk of contracting diabetes or heart disease or other chronic diseases. Then we're into the early symptoms area where clearly at this point, if we haven't already done it, we turn up at a general practitioner and start seeking advice and help. And then finally, we're into the active disease stage, where, of course, this is the expensive end of the spectrum. And it's been shown in many results that if you kind of analyze the overall demographics here, that 20% of the people in any given health economy generate about 80% of the costs. These are sometimes called the frequent flyers. These are the people that are in and out of the healthcare system constantly. So the concept here is if we can push the effort and the money and the research in healthcare systems back down this track here, then we can avoid people entering these two very expensive and very uncomfortable areas of the healthcare system until they need to. So essentially keeping people in these lower risk categories. We're also seeing an increase in personalization of medicine. If we kind of look back 100 years, you could say that essentially medicine was more art than science. Essentially, there were some scientific principles, but medicine was practiced by doctors who looked at the patient and examined the patient with their eyes and their hands and with maybe some primitive instruments, stethoscopes and so on. And essentially, we were looking at someone that was kind of assessing on what they saw in front of them, what they were going to do about a patient. As we've gone on, of course, clinical knowledge has improved and improved, and we now, and also patient information is more available in either paper or electronic format, and so we now move up to the era of clinician consensus, where clinical staff, know what to do based on much better and complete information about the patient and about medicine. We're now really in this, I guess, moving into this area of evidence-based medicine, where we look at entire populations and work out best medical and clinical practice and apply that to the patient. And we're moving into this area of personalized medicine, which is really the idea that, I don't care